So there'll be a lot of overlap, actually. So what I'll do is I'll try to go through pretty quickly and then try to emphasize points that weren't made before, because my charge was to talk about BPA specifically and then give some couple case examples. Just like the prior speaker, this is a team-based approach. So the folks on the team, it's not just me doing the BPA procedures, it's the medical pulmonologists, it's the surgeons, it's also, we have cross-disciplinary collaboration between pediatrics as well as ourselves, and then our imaging colleagues as well, and Akiko has obviously been here as well. So I think this is something that really needs a lot of people to come together and then come up with the best option for patients. So typically the way we do the referrals is if somebody comes in with CTEPH, we will get all the studies just as was described before, and then we sit down together and come up with what we think is the best plan. In some cases it might be medical therapy to start off with. In other cases it might be surgery, because clearly surgery is the class 1 indication for this type of procedure. And then if the patient merits BPA, then we'll do it in that way as well. The reason it's important to kind of go back to basics a little bit is because most patients that have pulmonary embolism, they resolve their clot and they don't have CTEPH, they don't even have residual disease. And that's one of the reasons why it's important to treat PE and DVT readily and aggressively, because this can occur. What happens though, in some cases though, is you get incomplete dissolution of clot. And if it truly is incomplete, and it becomes a hemodynamically significant lesion, these are the patients who need therapy. But before they need therapy, just as was mentioned before, they need diagnosis. This is the paper from the New England Journal that if you're curious how frequently does it happen that patients get CTEPH, the overall incidence in this paper of 314 patients with PE was 4%. But this may lead to underdiagnosis, and this may be an underestimate because there are people that have residual disease. And as you know, just from clinical medicine, many patients have recurrent events. And so these people may be set up for higher risk. This was already discussed. Really, you just need to have a high clinical suspicion. I can't tell you how many patients we see, I'm sure the same is true with you, where patients will have shortness of breath that's unexplained. It's because they're getting older, there's something else going on, it's asthma, and then you sort of take a better history and then do the studies and figure out that the patient has, RV dysfunction and then severe pulmonary hypertension. So in the age of echocardiography, it's harder to miss pulmonary hypertension, but not everybody gets the echo. And certainly if you have a suspicion, in some cases, there are compensated young patients who actually have a normal PA pressure at rest, and you exercise them, and that's when the RV starts to fall apart. I've actually had cases where the PA pressure, when we did the BPA, was normal. We then treated the first segment, and then the PA pressure went up because the PA pressure was normal because the RV was so dysfunctional. And we improved the RV function by doing the BPA procedure. We know that this can be mistaken for other things. This was already mentioned, but I will emphasize the riociguat. Is riociguat available in India? Yeah. So I think that, for many of our patients, we won't go straight to BPA. What we'll do is at least try riociguat, because if it works, then that's great. If it doesn't work, then certainly other options can be pursued. This is obviously the case for people who are not going to be going for surgery up front. And then if these things are not there, then you can do balloon pulmonary angioplasty. Obviously, you have to do the angiogram first. I'm not going to go through the other modalities because they were discussed before, but certainly a lot of other tests could be done to sort out what's going on. I will say that at our institution, because actually we get a fair number of young patients and we have good surgeons, most of the early questions are focused on what does the imaging look like? Is the clot proximal enough? And is the patient a good operative candidate? But one thing that's very important to emphasize is you need to have good surgical experience. If you have a CT surgeon that hasn't done a lot of these procedures, then you're not going to tend to want to do surgery. That's one of the reasons why in Japan, for instance, there's so much BPA being done, because there's sort of almost a cultural reluctance to go for surgery. Therefore, you don't go that route. Certainly, if you don't have surgeons who know how to do this well, you don't want to expose patients to a large procedure, as was discussed and shown before. So that's important consideration to make. When you look at studies of non-operability, this is in Europe, also in EU and Canada, a lot of this has to do with patients refusing and then other comorbid conditions. And so clearly, if patients are sick, they're much higher risk. They'll get benefit if they get through the surgery, but they might not get through the surgery at all. These are what the specimens look like. We saw some of this before, so I won't go through that in detail. I'll give you a little bit of the history of this, though, because it is kind of fascinating. And this was the first report that was done. It was a 30-year-old man. You can see the age of the angiogram there. And with BPA, the pressure was reduced from 90/25 to 78/13. There was improvement in the VQ scan and not much of a symptom change. I think that it's important to set the stage right when you consider these procedures. You'll typically make people feel better after several sessions of this, but it's rare to completely normalize pressures unless you're opening up, multiple occlusions like were shown. That ECMO case that was just shown before is a good example of that. You saw there were 3 totally occluded branches that were open quite well, but yet you also heard the speaker say the patient's being scheduled for an elective surgery for definitive therapy. So this is by no means curative. And the other way that I like to think of it is if you remember from your physics classes, the electrical circuitry, when you have serial circuits versus parallel circuits. If you have serial circuitry and use a resistor in the middle, you drop that resistor out, it has a profound effect on the overall resistance of the circuit. If you have multiple resistors in parallel, you have to remove many of those resistors in order to affect a drop in your overall pressure. And that's the same principle. That's why, as was mentioned before, you often need to target multiple segments and do it after multiple procedures in order to truly get reductions in pressure. Usually, though, after the first procedure, if you get a few segments, patients will symptomatically feel better, but to really normalize them, you have to do a lot of work. Now, this was an interesting finding. I think also what you can see here is there's residual disease, and we'll come back to that in a second. But this is not like a stent-like result that's being seen initially. Interestingly, though, at follow-up, it might be better because there's endogenous lysis that takes place after this initial balloon. So then there was a case series of BPA, and this was published in 2001. And unfortunately, in this, it was quite a morbid procedure. 11 patients developed reperfusion pulmonary edema. So once you open the segments, there's more flow. They get pulmonary edema. Some patients had to be intubated. And again, PA pressures dropped from mean of 43 to a mean of 33. Because of this, and this was a study done in Boston Children's in the US, there was a hesitancy to proceed with this procedure. And so what ended up happening is it then started developing in Japan, and really the procedure was refined in Japan, and now I think it's a worldwide procedure. Reason for that is because in Japan, as I said, the surgery was not the greatest thing. This is sort of the more refined approach in the Japanese series that really showed that you could reduce the rate of reperfusion pulmonary edema. Some had it, but actually this is why you don't do too many segments. This is why sometimes you treat with diuretics after you do the procedure. You watch the patient closely. And now, at least in our center, I'm sure it's similar as yours, we actually will send patients home certainly the next day, but even sometimes the same day if they are able to tolerate it and do well. And these are just the drops in pressure over time. Some of this was already shown. This is what it looks like by IVUS. You see the vessel is here. There's all this thrombus in between. And when you do the BPA, you sort of smush this to the side in that approach. This was the same picture you saw earlier. But I really want to emphasize what this procedure is doing is it's not optimizing a stent-like result. You're basically taking this mesh, this Swiss cheese, if you will, and pushing it to a side, and then in the chronic phase, allowing the body's endogenous lysis system to clear up the clot and to potentially remodel in better ways. This is just a nice paper that illustrates this. These are a variety of lesions. Here, you can see them. Here, you can't even see the lesion, but by OCT, you see this honeycombing and webbing. And after doing the BPA, you see how it's all pushed to the side. In addition, there's some pressure wire findings here where you see that the overall PDPA is 0.22. After doing the BPA, it's 0.59. And this is just another example of a case where you don't even really see this web here. This looks like a normal angiogram, but here by OCT you see it, and certainly by pressure wire you see this as well. So if you have high suspicion and you don't see a lesion, it's reasonable to take a pressure wire down the vessel and see if there's a drop in pressure. Because I've had cases where, our fellow will see this and they'll see me pulling out a balloon and they think I'm trying to dilate something that's not there. They can't believe what I'm doing. And then when you illustrate this, you can see all the difference in the OCT and what happens with the PDPA at that point. The other learning point of this is that there's stepwise enlargement of these vessels. So you do not go for a perfect result, even a one-to-one result up front, because if you do, that's how you can end up with perforations. And so this is a good example of that. This is what it looked like initially. This is post-BPA. pretty terrible result if you're a coronary angioplasty person. But look, at a month later, now you see this haziness there and the vessel's enlarged. So then you can do it again, and then 3 months later, everything normalizes. So sometimes you will come back and balloon the same segment again. So what I typically will do is I'll aim and target one area. I'll finish that. When the patient comes back for another session, I'll re-image the first session, do any touch-up work that needs to be done, and then move on to another segment as needed in that way. You saw this already. I do want to really emphasize this one here. This looks enticing because it looks potentially like you could get into these vessels. These are cases where you literally have to, you're literally a wire poke away from hemoptysis. And unlike things like pericardial tamponade in the cath lab with a coronary perforation, we know how to deal with that. A patient who starts hemoptysizing on the table, for most interventional cardiologists, is a visually arresting thing to see because we're not used to dealing with patients coughing up blood. During the procedure, if the patient starts to cough a little bit, typically pause, wait, ask them. You can ask the nurse to come and make sure there's no blood in there. And if there is blood, then that's a reasonable time to stop or to pull back or to think about giving protamine or something like that. And I typically will do these procedures on heparin. These ones are pretty straightforward. They're very straightforward to do. And a word about subtotal occlusions and other occlusions is that it turns out that they tend to be harder to do, but those are the patients that have the greatest drop in pressure when you treat them. So ultimately, as you get better at doing this, you can start approaching these occlusions and trying to do it safely. My approach into this was through CTOs, coronary CTOs. So I was using CTO-based techniques. I've used stiffer wires, I've used hydrophilic wires, but you have to do it really carefully because it's like doing a CTO of the coronary without a retrograde visualization. So it's much more of a feel thing than a visual thing, and that's important to see. In a couple of the cases before, some cases I'll show you, when you have a loop on the end of the wire once it crosses, that makes you feel very comfortable because, as you know, loops are pretty atraumatic. So this is the first case that I did. This is a lady who actually had pressures in the 90s to 100s. She had a syndrome with chronic lymphedema, chronic clot, and in fact, somebody had put in not one, not two, not three, but actually multiple IVC filters to try to prevent this clot from going to her lung. That didn't make sense to me, and certainly she still had clots. So anyway, this was sort of what happened. So in this case, we did an IJ approach because I didn't want to go through all those filters. Certainly you can go through one or more, but 3, 4 seems like a lot. And this was basically a sheath here. This is a big sheath. We didn't actually need that. In this case, there's another sheath here, and then a multi-purpose catheter, and you can see that there's no vessel here. So in this case, what we basically did is took a workhorse wire, and it seemed to go in where the vessel was, and you can see the loop was down here. We were cautiously excited and ultimately took a microcatheter and dotted through that. Now this, for expense reasons, might be too expensive, but I still think it's a safer way of proceeding than to balloon because the microcatheter has a lower profile. Clearly the microcatheter went, it seemed to be in the vessel here, and then we even measured in this case with QVA and then balloon, and then lo and behold, there was recanalization. So it's very similar to the first case you showed in this way. And when you see this happen, you're sort of literally eye-opening because there's no perfusion there, and then all of a sudden there is perfusion there. So she ultimately had other morphologies as well. This is a pouch segment here. These are segments that even now it's very hard to know how to do anything with this because you're just poking blindly. We've even tried cases where you see the pouch, you see the direction, you can try to line it up, but I haven't had success really poking through pouches very, very well, and obviously the risk is higher. This is 1 month later, and you can see where that pouch is, and she clearly has better perfusion there. And she went on her honeymoon and did better. This is just another case, subtotal occlusion in this area here, same sort of setup. This is our better setup now. It's a typically 7 French destination sheath, which is a long sheath that's placed into the PA. And then through that, we actually will go with a multipurpose or a JR4. Those are kind of our standard guides. For the upper lobe, you might want to take an AL1. I'll also mention that you have to be good at right heart catheterizations in these types of cases. Simple swans may go, but actually if you know how to do a right heart catheterization with a catheter like a JR4 catheter by coiling it in the right atrium, these cases can go much more quicker. And the same thing is true with acute PE intervention. So in this case, I used a trap liner. Again, this is more expensive than you might want to use with a microcatheter, was able to advance it through here. You can see the venous filling. That's another sign that you've done a good job because there's venous filling there. And then after basically going there, there's restoration of flow, better venous filling. And there's still this residual stuff here, so sometimes you might have to do it. So this is the same patient, symptomatically improved, able to go on vacation. Pressures go from 90 to 70 with improvement in our RV function by echo. And the question is what's next? I'll just go through really quickly. This is a case with a VQ scan, abnormal defect down here. You'll see this similar sort of lesion. There's total occlusion of down here. This was not able to be easily wired, and ultimately I took an 018 system and was able to wire here more freely. This is a glide wire M, so pretty atraumatic wire. And then after basically opening it, you can see here in the right place, then balloon dilatations are done, and ultimately it's a similar case of what you would see. Got recanalization of this segment here. And so you're happy that you were able to open that. Key questions relating to BPA. How well does it work? Is it more, if you have proximal disease versus distal disease, which is better, surgery versus BPA? How many segments, how many sessions should you do? The ties in of operator experience and lesion morphology. Who are the ideal patients? For us, it's typically going to be too high risk for surgery or post-surgery, just like he mentioned with the hybrid approach, and those are just ineligible for it. What should be the triage of these patients? Should everybody be doing this? I don't think so. I think this should be in a comprehensive center where you have all modalities at your disposal. This algorithm was already talked about, and I sort of want to leave with this in a sense. When you look at patients that have PE, they're going to be 50% have complete clot resolution, 50% who have incomplete clot resolution, and a small proportion of these will have hypertension. But there are a lot of patients with hypertension who are still underdiagnosed, probably about 5 out of 6. And then there are a lot of patients that have this residual disease that are set up for future failures. So at the end of the day, number one, think about the diagnosis, make the diagnosis, have a low threshold to consider it on the differential, and then refer patients to centers that can do this in addition to surgery and best quality medical therapy. There will be randomized trials with data that are coming, and those will be nice to see, but I can tell you that just having done a variety of procedures out there, this certainly works. So there's no question in a randomized trial this would be able to show benefit as long as it's done with good skill and with a low rate of complications. Thanks so much.